Thank you very much. And so at this point, with everybody's permission, we'll open the questions up to the committee. Forgive me if I miss the order of name tags being put up. I'll do my best. And so, Alan.
So I feel like Huda. Huda is usually the person who has a long list of questions. I have an extremely long list of questions, and I'll try to behave. I will emulate Huda and behave. Yes, I knew that. Can I start with you, Dr. Turplin? So what do we know about side effects during pregnancy? What do we know about use rates during pregnancy, compliance? I mean, there are like 20 questions around it that I can think of. But the most important one for the moment has to do with you said that it improves outcomes both for the mother and the offspring, right? And so what about the ideology around treating people with medications during pregnancy and immediate postpartum? What's the access rate for pregnant people? Did that just make sense in English?
I got it. All right. Well, there's the principle of care, which is treating chronic conditions in general improves things. There's a pharmacologic principle, which is, when we think about what we do for non-pregnant people with pharmacotherapy, it's stabilization. And that's also the risk of untreated opioid use disorder to the fetus is the multiple episodes of withdrawal that take place in the untreated condition. And those multiple episodes of withdrawal, which are in the untreated state, premature activation of the hypothalamic pituitary axis leading to poor growth and preterm delivery. And stabilization that we see in the adult when we treat is what also happens when we treat a pregnant person, that literally the intrauterine environment stabilizes. And there's not that repeated episodes of withdrawal, so pregnancies progress to term, normal birth weight, and if you want to kind of contrast from sort of public health burden, the burden of preterm delivery, like in the United States, exceeds that of, related to neonatal abstinence syndrome, which I would consider to be a side effect of pharmacotherapy in pregnancy. Access rates, if people get access to treatment, adherence with treatment during pregnancy is the same, if not slightly greater, than adherence with addiction treatment in non-pregnant populations. But I do think that there is a role for having like specific services that it can address the unique needs of pregnant people with addiction. In particular, like this is a population with a even higher burden of adverse childhood experiences and recent or past trauma, and have a multiplicity of other sort of psychosocial needs, which again, like the pharmacotherapy becomes the platform upon which you can deliver those sorts of things. So having care that is specialized and specific and in particular, like really just to crib Robert Bruner, like the core principles of addiction treatment, empathy and adherence, treating people with dignity and respect to get them to come back.
Good, thank you. Can I do one more? Okay, then I'll behave better. Dr. Rich, what can we do to help, other than pass laws that force them to do it, help get people in the criminal justice system to be willing to use agonists in treating people? The data by now are extensive that treating people while they're incarcerated or in the criminal justice system is a good idea no matter what metric you use. But the ideology that surrounds medications is a very tough nut to crack. Do you have any advice other than talking the governor into passing it?
Well, so we work the political system with the governor on down, and departments of corrections tend to be military hierarchical structures. So that's why I pointed out that the director, was, told that he had to give marching orders to the people below him, and that worked. We look at law enforcement and look at 3 years ago, no police officer carried Narcan. It was just, no, we don't do that. And now it's, of course, everybody does it. So, I think the rules that we've played by for the last, are all different. And when we look at correctional officers, we look at law enforcement, they've been impacted personally. In Rhode Island, we've had 1,500 deaths in the last few years. We only have 1 million people. Every family's impacted by this. So I think there's a lot of opportunity at this point in time. Vermont has this wonderful hub and spoke we heard about yesterday. They just passed legislation that's saying, okay, you must do it in corrections, and they got all kinds of resistance. And I've been talking to people there, and in fact, just yesterday they decided, okay, well, fine, we'll go ahead and we'll do buprenorphine for everybody. I think it's going to take some time, but just like the police officers carrying naloxone, once you get a movement, nobody wants to do. They all want to do what their neighbors are doing. So if these guys are doing it, now I also would point out that the only thing that's really changed healthcare and corrections has been litigation or threat of litigation, and the Justice Department is pursuing some American with Disabilities Act because people on MAT are a protected class being on MAT. And they got the green light from the Trump administration to pursue that in a couple of jurisdictions, so that's big. And I think, this has got to be fought jail by jail. And so, having litigation, having successful suits is really going to drive this.
So I have a question for Helena. Your presentation resonates very much with me, having practiced in the Bronx for 20 years, and about the color of the opioid use disorder and opioid epidemic. So I want to get your thoughts on two things. So one is, we heard earlier yesterday from NIDA about the Healing Communities RFA. So $30 million per year over 3 years to 3 sites across the U.S. And the RFA is written in such a way that it's focused on rural populations, which equals white populations. So I want to get your thoughts about now that as being part of the focus with tremendous resources. And then the second question is really about potential solutions. So criminal justice clearly is one area where, people of color are overrepresented. But I'd like to get your thoughts about methadone versus buprenorphine, the role of FQHCs, and around messaging and stigma.
Thank you. Here we go. All right. Is it on? Yeah. Thanks so much, Shinazo. So I think the first question was about our investment in rural communities, which is very important. What I didn't get to talk about along the lines of inequalities or disparities in opioid overdose and also in treatment is that we're now seeing, and you've documented much of this yourself, we're now seeing multiple overlapping epidemics. And so the epidemic in rural America, and largely rural white America, at least that's what the media is portraying, does bear a direct relationship to the prescription opioid phenomenon and the deregulation and aggressive marketing of opioids in those communities, as well as suburban white communities that didn't trigger DEA surveillance and public resistance to the same extent because the consumers weren't seen as at risk for addiction in the same way, largely due to the kinds of imagery that I flashed up on the screen, that addiction has so long been linked to black and brown people. And so those communities are experiencing this second and third wave of the opening up of heroin markets after prescription opioids led the way in these communities, and now fentanyl, which is leading to a lot of overdose deaths. So what we have to do in order to have a population impact with healing communities, with other interventions that are really looking at community level dynamics, is to address the multiple different but overlapping epidemics. So alongside the rural prescription opioid-driven epidemic, we also have the populations that, for example, you're treating in the South Bronx that have seen heroin overdose for many decades. And again, fits very nicely actually into Ann Case and Angus Deaton's deaths of despair hypothesis. What the difference there being that heroin became a leading cause of death decades earlier because deindustrialization and unemployment and divestment in those neighborhoods happened decades earlier. And so in order to have a population impact and equity in that, we also have to have direct funding and research targeting those communities with those epidemics that have a different time course, a different temporal course, a different politics around what is community and what's necessary to reinvest and rebuild opportunities and connections there. And also would need a different kind of attention when it comes to what's going to lead to more access to medication, among many other things that are necessary there. Your institution, Montefiore Einstein, being exemplary in having taken up a full range of opioid agonist therapies from the beginning. And that was really led through my oral histories that I've been doing as a part of my research by community activists and physicians who were justice-oriented and very concerned about the inequities that they're seeing in health outcomes, really launched during the HIV epidemic. So that kind of very proactive engagement of community members with clinical providers is going to be necessary all over, but I think the model of Einstein Montefiore in South Bronx is one that needs to be invested in and cultivated in many other sites where urban Black and brown communities are definitely seeing a steep increase in overdose deaths on top of what has been for many decades an endemic problem, much of it tied to incarceration and the risk of overdose after release from prison. So that's another phenomenon that would have to be directly addressed, and connections and community resources would have to be targeted to people who are imprisoned, their families who are seeing a disproportionate health impact from having a whole cohort of people removed through mass incarceration, very racialized mass incarceration from their neighborhoods as active contributors and family members. So we'd have to see that kind of focused attention in low-income Black and brown communities as well.
So I have Colleen and then Yasmin and then Huda.
So I want to pick up on that point that you just made, Helena, and then I have a question for Jody as well. So Helena, Samuel Kelton Roberts has written as a historian increasingly eloquently about the historical legacy of distrust of medication and methadone in particular among Black urban communities. And to the extent that we identify an evidence base around medication, are there strategies for trying to sort of transform views within these communities about the role that medication can play in treatment? And then Jody, you noted that most critical was being able to connect individuals with treatment in the community as they move out of justice settings. But where does that treatment community infrastructure come from, to the extent that we have such high rates of sort of supply challenges? And what were you able to do in Rhode Island around, was it specialty OTP? Was it office-based? What was the quality? And how, in convincing providers to open their panels to individuals that were leaving incarceration, did you deal with sort of the double stigma of justice history and OUD, and maybe the triple stigma of race?
Thank you for that question. It also reminds me that there was a second question that Chinazo raised that I didn't address, but I think the answer is very similar to the answer to your question. In Black and brown low-income communities, there is a tremendous suspicion of healthcare providers. And one of the aspects of Sam Roberts' history that is pertinent here is early resistance to methadone. So in that context, so this comes back to methadone and buprenorphine and what kinds of targeted approaches might be needed in communities that are really underserved, hadn't been targeted in the first decade or two of buprenorphine marketing, and actually in some cases specifically avoided in terms of buprenorphine marketing because the association of an addiction treatment with Black and brown populations is it's death for an industry that's trying to get a very difficult and stigmatized product off the ground. So in Black and brown low-income communities of the type that Sam Roberts is writing about, it's even more critical to pay a lot of attention to how the medications are offered up and what goes along with them. So I'll speak from my experience at Bellevue, which serves an extremely diverse population. One thing that got me on my train of research, kind of the history of racial inequalities in medication-assisted treatment, was seeing that in Bellevue, the largest public hospital in New York, curiously enough, the majority of methadone patients were Black or brown. The majority of buprenorphine patients were white, even in that public hospital. This was really curious to me. And that's what launched me on this trajectory of looking at how buprenorphine was deregulated, marketed, et cetera, and the implicit racial targeting in that. So at Bellevue Hospital, what I am seeing as really the successes of long-term adherence and recovery come from a deliberate packaging of medication together with social services and beyond that even community building and connection building. That's what the last panel yesterday ended up focusing on. So I'll give you an example. The chemical dependency outpatient program where I work has an extensive art therapy program. It has a patient government. It has a sobriety garden in the back of the hospital in which patients plant and cultivate and harvest alongside staff. It has a lot of deliberate social technologies for fostering connection in a population that's largely homeless, largely criminal justice involved. And that kind of fostering of connection along with assistance with housing, basic needs, is necessary for people who are coming from communities that have long been divested, where families are fragmented, where daily survival is very difficult, and where the introduction of a medication from what is perceived as an outside, foreign, and essentially white institution can be seen as yet another threat. So that's really my pitch for we have to pay very close attention to the context of the medication and its provision and community engagement and fostering of those sorts of ties. Thank you.
So, first of all, I'd like to say that this mass incarceration and the racial disparity is really an abomination, and I want to make sure that the message is not, oh, we can connect people to MAT when they're incarcerated, therefore we should incarcerate more. Absolutely not. I mean, people will say that, so that's not the message. But while it's there, we should take advantage of it. And the magnitude, there are 10 million people cycling in and out of jails every year, and about another 700,000 in and out of prisons. So and if a quarter to a fifth of those have opioid use disorder, there's a tremendous opportunity to make a difference. And if we can capitalize on that difference, knowing that the racial disparities in the system, we can actually offset some of the racial disparities in the community. So I think we should certainly work towards that. As far as, if you look at the map of the country of counties that have buprenorphine providers, it's about half of the country is blank. So if you have a county jail in that community, it doesn't make sense to start someone on buprenorphine and discharge them. You really need to build up the capacity to take it, and building that up is all the things you talked about, the high quality and willingness to accept people with double and triple stigmatizing conditions. In Rhode Island, we were very fortunate. We have an extensive network of methadone treatment. We have widespread availability. The largest and only not-for-profit program called Kodak actually has a contract with the Department of Corrections to come in and sign people up and do the dispensing at the Department of Corrections. So when I see a patient there and start them on methadone, they actually become, or buprenorphine, or naltrexone, although that's extremely rare, they become a Kodak patient and logged into the Kodak's computer. So information exchange on this transitions is very challenging. So we tell people, because people get released all the time, we don't know when they're getting out. They don't know when they're getting out. They just get out. They said, there are Kodak locations all throughout the state. So just, the day you get out, show up at Kodak and say, hey, I'm a patient. They'll look you up and they'll say, oh, yeah, you're due for your dose. Here you go. And Kodak and we also are an expansion state, so we sign people up for insurance before they get out, everything but push the button and say go. If they haven't completed that process by the time they get out, Kodak has agreed to continue that process and dose them anyhow. So we're very fortunate with that. Now, they are not obligated to stay with Kodak. They can go to whatever provider they want, but there's that backdrop. And I think that's really been critical to our success.
Well, Jody, you answered part of my question about continuum of care, and I have a few questions for different people, and I was just wondering about what you think of getting more people within the justice system to quote-unquote sign on if they're extended release formulations that are promoted. Do you think that would be more successful than, methadone daily opioid agonists?
So there are thousands of correctional systems throughout the country. There's maybe a few hundred that have any kind of MAT on a widespread basis. The vast majority of those are so-called, are just depot naltrexone. And I would say our first 1,000 patients released on MAT in Rhode Island, about 500 were on methadone, about 500 were on buprenorphine, and maybe less than 5 have been on depot naltrexone. And we offer it. People just aren't. It's similar to the Vermont experience. People just don't want it. But I would say that I'm losing my train of thought. So.
The buy-in from
the. But that said, Vivitrol, in my mind, being a second-line treatment, that's number one in terms of correctional mentality. It's custody, it's control, it's now they can't get high. It's because getting high is somehow bad. So that's the mindset, and we put it into you, and now you can't get high for a month. That's gonna be good. It may be good, it may not be good. And they've. There's a lot of diversion of buprenorphine, so they consider buprenorphine as the enemy. So they, any buprenorphine is bad. The more, the worse. When in fact, the real problem with illicit use behind bars is fentanyl, and we've had a number of, very close calls, and there's been a number of deaths around the country with fentanyl. Really, just spillover from what's going on in the community. It's grim.
And is there any data in terms of follow-up after, since you have a program where there's continuum of care, in terms of who does better, in terms of what they might have been treated with while incarcerated, and who continues and do better once they get out? So
that's an area of active study. I will say I've made some clinical observations, which it struck me. This is one of the only places you can show up and you have the full menu.
Yeah.
You go to a methadone program, you're going to get methadone, and so patients tell me, some of them say, I just can't do the methadone. I don't feel right. I'm groggy. I'm sleepy. It just doesn't work for me. I can't get up in the morning. But yeah, when I take, buprenorphine, they all call it Suboxone, I feel energized. I feel great. Other patients say, Doc, I've tried buprenorphine 3 times. Each time I take it for a few weeks, and then I don't feel right, and I end up selling it and buying some dope. And and I suspect there's a biological difference there, that there are some people that are going to do well. So this question yesterday about, well, which is the right medication for a right person? I mean, to me, all 3 medications work if you take them. So really, the key thing is, are you going to take them? And to me, the most important thing about are you going to take them, especially if you've tried them before, is which one works for you.
And thank you. And
Yeah.
Helena, the question about, which medications are targeted for different racial groups and rural and urban, one of the things that is important also is the education perhaps of the clinicians. And I'm talking about from social workers, nurses, and physicians, because in certain programs they do believe methadone for their patients and do not believe like in Suboxone and so on. And those populations often are urban. So do you think that there should be more education, that there's bias even in the care providers perhaps as to which one may be beneficial to, as Jody just said, different people might like different things?
So we had a panel yesterday on education, right, that was just a taste of how big the need is for not only education and what the pharmacological properties are of the medications, but what is the context for use for our patients. And that's where trauma came up, that's where peer support came up, that's where the need for housing and sustenance came up. You're at an institution that also is quite exemplary in taking up social determinants approach in the curriculum. So this is an era of clinical education where the term social determinants is beginning to be mouthed in classrooms. Traditionally, that social determinants frameworks had been reserved for public health, for schools of public health that had been cordoned off. And we're now at a moment in time where it's becoming obvious that social determinants have such a direct impact on our patient populations and their outcomes that clinicians also have to be involved in thinking about how they can help address them. So why am I mentioning this? You raised what would we have to do to educate our clinical practitioners. They need education about the role of many different approaches, ranging from harm reduction. Harm reduction is rarely taught in medical curriculum. And harm reduction has to be a real foundational philosophy when it comes to patients who may not adhere to treatment, patients who may not accept treatment initially, that trainees are going to see in the emergency room or inpatient settings and are going to get frustrated by. Social determinants perspective on what leads patients to addiction and to the hospital in the condition that they present in is really necessary for destigmatization. Stigma came up yesterday, and in fact, the degree to which clinical providers are active in promoting and propagating stigma against people who have dependence. So a social determinants perspective is equally as important as a brain disease perspective on addiction, because without an understanding of social determinants, clinical practitioners will see patterns, demographic patterns of people who can't adhere to treatment or who don't present asking for treatment, et cetera, who aren't good patients, quote unquote, that also fall into race and class stereotypes. And they will mouth a brain disease philosophy, but also continue to practice in a way that reflects a lot of bias. So that's where social determinants needs to be a very important piece of clinical training and education.
One fast, quick, and then in terms of, and also Mishka, the continuum of addiction from the prenatal to geriatric, we've not focused that much on geriatric opioid use the stigma, the treatment. Again, what evidence or do we need research on what may be most effective in a geriatric population that may not be in a younger population? And I know that's the outcomes for a geriatric. So
Sure.
do you, it's in terms of, is there worsening of a particular cognitive decline, some of the comorbidities of their medical conditions? I just wonder, yeah.
So in addition to the standard biases about mental illness and opioid use, there's an additional bias that comes into the elderly, which is the assumption that most of them have sort of passed their most productive years, so why bother? I'm not saying everyone has that, but there's a widespread sentiment. When we talk of the opioid crisis, not just physicians, scientists, the lay press journalists, there's a sense that Big Pharma made us do it. Well, that's part of the story. But physicians are the ones who prescribe. We need to, and many groups have, take responsibility for what our brethren continue to do and have done. True, we were seduced by pharma, but it didn't take a heck of a lot of seduction in some cases, right? I mean, we quickly bought on. And this is what happens in the elderly, that prescribing practices, easier to write a prescription. And the data I gave are from non-cancer patients. So largely musculoskeletal arthritis, and some of these are painful, limiting conditions without a doubt. Where the data are lacking, where more research needs to be done, is in sort of methods of self-management of pain. There's some data showing that it's effective. In terms of, they include a variety of things, sort of relaxation, talking about living with some of those limitations, not in case of severe pain, but there needs to be some discussion about these things, autonomy, what other help you can get them in ambulation and things like that, mechanisms that might then reduce the physician tendency to write a script. When a script is written, there should be, whether it's optimally not from restrictions and legislative, optimally it should be internal, come from education, it should be a very time-limited opioid script, as opposed to, because that's a rapidly growing segment of the population, and it's very easy to see how everything starts, not everything, most things start with good intentions, alleviate pain. There's so much data now compared to when this whole business started, like in the case 20 years ago, when the pain was, alleviating pain and suffering was what physicians do, et cetera, et cetera. The dangers are very clear now. But prescribing habits should change, and other forms of non-pharmacological intervention. And if you want to get into pharmacology, non-opiate forms of pharmacological intervention, I think needs to be boosted up.
And with race, because, black and dark. Oh, yeah, that's true. Huda.
Thank you. This whole discussion is so important. And I was actually, as I was going to sleep last night, thinking we've been talking about it as if it's a standalone problem, but it's a problem embedded in so many other issues, including social and other illnesses and an arc in life. And so I really appreciate everybody bringing this up. And in fact, Dr. Hansen, you brought up the sort of the contrast between the approaches in neuroscience and in a more, public health disparities, etc. approach. And my hope is that this would be also a place of integration. I think any good neuroscientist would understand, I hope, that, any of these processes are not hitting just a standard brain. They are hitting a brain that's been affected by not just the biology, the genetics, but the growth, the social context, the stress, the antecedents of what went on in that brain really matter in how you're going to respond to even, and just as an aside, by the way, I have a colleague who literally gives drugs of abuse either in the animal's home environment or in just a different cage. And the consequences on the brain are really different. exactly the same treatment, just different physical location. And we're talking about a rat. So, really context matters at every way we can. And I just this is more of a comment that I hope that we can move away from the tensions potentially from these perspectives. And as scientists, I hope that we can incorporate more and more of these other integrative perspectives. And then I have a follow-up question to Dr. Kumar. Yeah.
Should I respond very quickly? Okay. So very much a statement after my own heart. I co-organized something with Dorothy Roberts that we call the Biosocial Network, and it's precisely to address that problem that there's been a siloing of life science from social science for far too long, and emerging paradigms such as neuroplasticity, which is something you're describing, epigenetics, microbiome. These paradigms are making it very obvious that we have to have a sophisticated understanding of the interaction between social context and biology, and that the two mutually shape each other. So I think that's the next generation of life science, actually, and hopefully social scientists will be there to collaborate to make sure that those models have robust understandings of social systems as well as biological systems. And I totally agree with your sentiment that the neuroscience of addiction should not be seen as at odds with the social science of addiction. That we desperately need a knowledge base that draws on both and understands how the two interact. And so that's one reason that I am excited about social determinants being a part of clinical training, and I'd also like them to be a part of life science training. So that's a very broad statement, but when it comes to addiction, can you think of a more quintessentially biosocial condition than addiction? And so the current crisis opens up a window for us to really act on that opportunity. So thank you for that.
Yeah, thank you. So absolutely, I would say that our neuroscience community, it's tempting, and I'm making this point because I want to make, I have a question, believe it or not, which is that the drug is such a dominant force. So you take, in an animal model, you take it and it erases individual differences for the moment. It doesn't matter if the animal is thrill-seeking or depressed or whatever. You give a drug and the effect of the drug is very powerful. And that's all you see, and it's very compelling. And the analogy to, hey, the drug is a drug, it works in human, it works in a mouse, is very good. But what we forget is that there is time before why you choose to take it. Even in an animal, I study that, but also there's time after. Which takes me to my question, Dr. Kumar, which is that you talked about the comorbidity with affective disorders, for example. And what I don't understand is how much unpacking there is about them being either antecedents or consequences or both, how you deal with them separately and across the course of treatment, how that gets deployed, or whether we need to think more about how that intersection gets worked with.
Sure. So when someone acutely shows up in a research study or in a clinic with addictions as the presenting feature, and you do a comprehensive psychiatric assessment, mental status assessment, and say they also have major depression, cross-sectionally at that point it's difficult to separate what used to be called, primary depression and secondary, all fancy words, but nonetheless, there's some secondary depression denoting that it's the drug use, it's the drug use that's contributing to the depression. But after the acute phase, if one can think about a washout, before someone enters any given treatment trial, after a period of observation, if that's possible, it becomes more clear. There's still going to be some ambiguity, and I think prior history, family history of mood disorder, for example, using mood disorders as an example to make the point, will help. Regarding treatments, so there's two-pronged. So the term that I used, from where I sit in psychiatry, one of the less heralded successes in psychiatric treatment is psychotherapy for the last 10, 20 years. I didn't think 10 years ago I would say something like that. But the data speaks that we've gone through a whole generation of SSRIs, 20 years, and drug placebo differences are modest. So in the elderly of patient population I'm reasonably familiar with, Placebo response is about 35, 36% in major depression studies. SSRI response is about 46. Life was simpler when I was a resident. We had tricyclics, about 66% of patients responded. Placebo was about a third, 33%. So it was worth the risk, if you will. That's gone down. And gone down considerably to the point that one might ask legitimate questions. Why are you giving another drug to someone who's coming in for addiction treatment? I have a small quibble with the word counseling. Counseling, the reason is, we all understand what it means. It's easier sort of to explain, especially to the lay person. But there are several evidence-based psychotherapies that have emerged over the last 10 to 20 years, CBT being one of them. These are not just behavior-altering, mind-altering, they are brain-altering. There are neuroimaging studies that show that CBT changes glucose metabolism in comparably the same areas as a pharmacological agent does. And I think whenever possible, using these, whether it's family therapy, CBT, or whether it's motivational interviewing, there are a variety of reasonably well-studied non-pharmacological approaches which might be, in some cases, better suited to managing anxiety and depression in the context of addiction maintenance. And I'm not saying don't use pharmacology. It's easier to use pharmacology. That's how we got to this in some ways. Easier to write a prescription and say, hey, take it. But this is not the flu shot. I'm not disparaging the flu shot. I take one every year. And some years I get flu despite the flu shot. But that's another story. This is not the flu shot. It's not the pneumonia shot where you take it every 5 or 10 years. This is something that needs constant support, monitoring, etc. And this is a patient population, the medical treatment of opioid use disorder, that is difficult to engage, that is difficult to keep in treatment. And I think the 25, 30, 50% in some studies of antisocial personality disorder is a contributing factor. These are not necessarily the most compliant patient population, but that is the patient population. That is what they have. So consequently, I think in getting into treatments, we stop. Yes, trying different approaches, psychotherapy, especially evidence-based treatments, I think is the way to go. Thank you.
Thank you for that. I really appreciate the clarification of what we mean, with the difference between counseling, which is so broad as to be, I don't know what it is, and versus, well-done evidence-based therapy. Okay. The microphone is here and he's there. But Dr. Kumar, one of the things that we've not discussed yet, and I guess it belongs in this, is sort of what do we know about suicide and MAT and sort of reduction of suicide? And because suicide, what's overdose and suicide seems very complicated to me. Do we know anything really about MAT effects on suicide, or how does that?
Yeah, I don't really have that much to add. I mean, I think there's always some question if there's a suicide note and there's, then it's suicide, and if there's not, then you kind of have to use the best judgment about the evidence at the scene. But I think the sense is that the vast majority of these are accidental overdoses, that people are, they're living their life, they're doing other things that wouldn't suggest. But there's some ambiguity there.
Yeah, most of the published information suggests that these are accidental deaths, these inadvertent suicides, if you will, because of sort of products that are contaminated or not knowing the regular dose. I'm sorry, am I speaking? Oh. Oops, sorry. Oh, okay. That these are inadvertent suicides because of either product contamination and not knowing when to stop. But in cases, I think, the patients you see in treatment, if there's coexisting a major depression, for example, I think it behooves us to do a complete assessment, including sort of potential for suicide. There's so much to do and so little time. But nonetheless, I think, I don't think anyone here will recommend ignoring coexisting psychopathology. And it's hard to do everything. But this is an incredibly complex patient population. And this is, not to belabor the flu shot example, but number of therapy sessions, how often do you see them, and other approaches. And there's data to suggest that the integrated team approach, whether we call them navigators, whether we call them case managers, APNs, someone they have a connection with in the clinic. And may or may not be the MD who's the medical director. Could be, but.
Could I add to that very quickly? As an addiction psychiatrist, I've long been really interested in buprenorphine as a primary care-driven phenomenon. And one of the dangers of thinking of it as something that can be neatly dropped into primary care alongside asthma, diabetes, and hypertension is overlooking the fact that we know from very good data that the vast majority of our opioid-dependent patients have psychiatric comorbidities and what to do with that. And what I'm seeing in my studies of primary care clinic adoption of buprenorphine is that that is a huge lacuna. Many primary care clinics don't have those resources, don't know what to do, and they're seeing a very high dropout rate from treatment, which is, it's pretty clear that much of what that has to do with is the unaddressed comorbidities. And so I think that your point is extremely well taken, that as we go forward and we see that we have to face the complexities of our healthcare system and the way that it's structured, but that the current attention, national attention to opioids and the opioid crisis opens a window for us to make some of those structural changes, that kind of integrated care that you're mentioning should be high on the agenda. How can we bring mental health resources into the mix as well? Without that, we're going to continue to see high dropout rates, and we're not going to see the public health population level effects.
Thank you. So, Dr. Turpin, you might have been the first person here on this panel, I might have missed it, that basically said patients are not able to even get into treatment. And so we work with a large state safety net program where every morning they show up to work, there's 5,000 phone calls, and they get through about 1,000 of them. And then the next day, there's 5,000 more phone calls. And I think we say, oh, if only more people would get treatment, more people need to get treatment, and that would be a blessing, but it would also sort of be a curse that there would be 10,000 just because of our structural programs, and maybe everybody has something to say about that. But also another general question, we heard from the FDA that there's new medications in the pipeline, and that looking at how the FDA approved these past medications, would you guys have anything to say about who might be involved in who would be the sample in these new medications? Is it important to include some of the populations specifically that you address here?
Well, I would just say that it's great to have new medications, but the pricing is outrageous. And so in your state, Missouri, where there's not Medicaid expansion, there's very limited option, even for someone to, you have limited methadone, you have very limited buprenorphine. I would say, expanding treatment and getting 10,000 calls is great, because then you need to, it highlights what you need to do. Unfortunately, your politicians have not really moved forward, but this needs a political solution. You can't have people with no access to care, no medications they can afford. I just met last week with a bunch of infectious disease doctors in St. Louis, and they're hospitalizing patients for 6 weeks to treat them for infectious antibiotics from their addiction, and then they go out the door and put on a waiting list to get into a methadone program, and then either just don't come back or get reinfected or die. They go live in rural areas. There's no buprenorphine prescriber. They can't afford it anyhow. So, that's a real problem.
We talk about that the term like addiction is a chronic relapsing condition is common and well dispersed, which is probably not untrue, but it probably actually reflects the historical reality that we've mostly only ever provided episodic care. So it's chronic relapsing because we don't provide continuous care. And so we are, in my state now, Virginia, we're like on the precipice of a large experiment of actually paying for and providing services through Medicaid for addiction treatment across the life course. And I think we will see how chronic relapsing it really is. So I think a lot of our assumptions about it being a difficult population, complex, all of those sorts of things, that they're not untrue, but they also they emerge out of the historical social context in which we have actually not provided addiction treatment services. I think drug development is important, without a doubt, but access is more important. And I think we have valued certain domains of science over others, and the whole implementation, i.e., public health part of things is deficient in comparison. And then the final thing just related to Medicaid. So there have been, my state expanded enhanced reimbursement services for addiction treatment across all levels of care as a way to increase access. And there has been phenomenal growth. The number of pregnant women who had Medicaid who received treatment went from 3% to 17%. So that's like a 600% increase, which looks great one way, but the other way is most people still don't get treatment. But within states that have looked at this, and this is from Vermont, 40% of all of the money spent were on drug testing, which is a critical part of addiction treatment. But if you balance that against the other things of what services are. And the final piece, and this is unique to Virginia, is that we got funding for care coordination for office-based practice. So for every Medicaid patient, you have to submit some paperwork to get, and it's $243 per client per month. And that is a way to try to operationalize the whole biopsychosocial spiritual part of addiction as a process and into clinical care. And utilizing peer services and things that I think have been discussed are key to kind of realizing that.
Great discussion. So one of the questions I have relates to the examples that Jody has given about the criminal justice system and some approaches that have been applied and how they've been working, and sort of getting a feel for best practices. And I'm wondering if you can think with us, for example, of what are some best practices, some examples of programs, for example, with the elderly. Are there some that we can point to that we could look at and say, given all these barriers that are out there, which ones work best, and that we might look at a little bit more closely? And I think that would apply not just to the elderly, but thinking about the OB as well as, again, we've got some model programs here among people in the room, but just help point us in the literature a little bit more.
There's a group called the Aging Network, which is involved nationally in many of these sort of opioid-related issues. And a specific shot, and they have some clinical trials, though relatively few, is that sort of self-medication management approaches, especially in the elderly, before going on to pharmacology, especially before going on to opiates. Because we've all heard the cliche, an ounce of prevention, and prevention's better than cure, etc. In this case, it's true. It's true in many other cases as well. So some of these approaches which talk about discussing living with pain with the patient, starting with that, sort of spending time with the patient in pain. Because some of them go through, these are serious conditions, severe arthritis, for example, which is what a lot of the elderly have. Talking about relaxation techniques, talking about sort of potentially massage therapies, engaging them in other activities. Simple steps, but they could be meaningful steps in trying before going on to pharmacology. And once you think about starting pharmacology again, going on to non-opiate approaches as much as possible. This is, again, a rapidly growing segment of the population, in addition to the usual issues, there's the dementia problem, which is massive. And you're talking about individuals who are, at least, not for the most part, but at least for a significant proportion of them are living either alone or with very little assistance. And all these things add up in their population. So I think the aging network information and we need more data definitely on self-management of pain and some more clinical trials on that to see how effective and which of the different populations are more likely to adopt than others. It's a long, hard slog, but nonetheless, so is everything in medicine, so is everything in healthcare, right? Nothing is easy. How we would fix this.
I would just add that, the assumption is that people should not be on opiates unless there's a really strong reason. And, I think it's, as a clinician, there's a risk-benefit. And there's a lot of people on prescription opioids that are stable, that are doing fine. And when the rush to pull back on opiates, a number of those people are going to not only suffer pain and withdrawal, but are going to turn to illicit opiates and much more dangerous practice. So it was just being my.
Sure. That's an important point. It's sort of we don't need to rush out of it, but we need to learn some lessons from what we've done. And I think a very cautious approach and individualized patient care, all those things are very critical. There's so much emphasis on personalized medicine. There's personalized clinical medicine. Well, most people talk about personalized medicine. They speak of personalized molecular medicine, which is relevant only at this point, a few cases of oncology where genes can predict. And hopefully we'll get that, but in many other cases. But that's not where we are. So I think individualized treatment plans and treatment programs, giving opiates when required, but needs to be monitored. It just cannot be, I shall fill this prescription for you. We run into a risk of unmonitored use of any addictive substance. I think even when the intentions are very good, or perhaps especially when the intentions are very good, we need to be careful.
Can I just mention we've got about, I'm looking at the number of people, we've got about 12 minutes.
Well, I just had a quick comment about, you were talking about model programs, and there definitely are, for, like I said, for 50 years, there are model programs for how to care for pregnant women, co-located, integrated care models. I think the issue really is, and most of the literature emerges from those programs. We have a bias in the publications. The programs that do well are present in the literature, and those that aren't. And so, but the application of those, they're all, and there are good reasons for this, like they're all sort of like urban, and they're all like, geographically proximate to the patients. I think we have opportunities, though. I don't think you take a model program and just drop it down somewhere. We have to think about sort of like person-centered care at the level of the clinic. But there are a lot of opportunities, I think, in particular in terms of telehealth and sort of new technologies to, to speak to like sort of geographic barriers that aren't actually only non-urban. In terms of applying these models, both like the counseling and all sorts of different the pieces we've been talking about can be thought of as being delivered through remote, in addition to local.
So I had a very specific data question, and you guys may not have the answer, or you may. So for the specific populations that we've been talking about, do we have rates of OUD and rates of utilization of MAT? I think you mentioned 1 in 5 for the criminal justice population, because I think understanding that is important to understanding the barriers. I'm probably most familiar with the barriers for pregnant women, why they don't seek treatment, which is they're terrified people are going to take their children away, and that's why they don't seek treatment. But I was just wondering about the incidence of OUD and the incidence of utilization of MAT.
So yeah, in corrections, it ranges from 15% to 25%, something like that, and depends on how you measure it. But MAT is 99% non-existent in this population.
Go ahead. No,
So just a brief comment that you'd see a lot of variation based on the region and based on the treatment opportunities. So even within New York City, for example, I actually mapped out methadone and buprenorphine utilization in the 5 boroughs, found huge variation, largely along the lines of what we might expect, that methadone was concentrated in low-income black and brown neighborhoods that had been targeted since the early 70s for methadone treatment, and that buprenorphine was concentrated in places like Staten Island that have high percentages of white residents, and Staten Island being the most affluent of the 5 boroughs. But there were exceptions. So, for example, in the South Bronx, there's an exception there where both methadone and buprenorphine are highly utilized there. And there's a local history to it, which is an institution and a set of institutions there, but largely led by Montefiore Einstein, that early on in the HIV epidemic very proactively pursued opioid maintenance treatments and introduced buprenorphine very early on after its approval as well. So what that suggests is that rather than looking simply at the national rates, we want to hone into those regions that have high utilization rates among populations that traditionally have not gotten access and ask, what are they doing properly? How can we replicate that elsewhere? So I think the regional variation is actually informative and important in this.
And I'll give you the references before I leave. In the elderly, it's one of the most rapidly growing segment of opioid use. It is estimated that, and not a lot of data, but there's some data that the CDC and other groups have reported on. That's the 25% of the prescription opiates, they estimate, of people 65 and above. Which is alarming. I'm sorry, I can't hear you. That is use, not use disorder. Yes, that is use. Correct, that is use. And not, I agree, point well taken. Not every case of use leads to use disorder. But typically that's where it starts. The risk is high when you use, and if you don't monitor it adequately. Again, let me sort of make nuanced statements. This is not meant to say opiates are bad. As Dr. Chuck O'Brien said yesterday, some severe forms of pain need opiates. This is historic. Meaning he used the example of the Civil War, and it's correct. Severe pain is what you need. But that, given in the clinical sense, does very implicitly mean proper monitoring, adequate dose, and sort of with an eye towards duration of treatment. Especially when you're talking about polypharmacy in the elderly, especially when you're talking about other potential things like falls, the complexities and the side effects become much larger when you talk about vulnerable populations. And I think we need to recognize that.
So this is our 3-minute warning.
So yesterday we talked a lot about the workforce, and I think a lot of the discussion has been focused on primary care. So I'm interested in hearing, Mishka, from you and Anand about workforce issues around OBGYNs and the sort of role that belongs in that sector around buprenorphine treatment, bringing not just the sort of integrating pregnant treatment in methadone, but the opposite of in OBGYN settings, integrating buprenorphine. And then also in terms of psychiatrists, I've been quite frustrated in terms of the role that psychiatry has played. Obviously, we have addiction psychiatry, but that's a very small number of people. And so if you could comment on the role of psychiatrists in opioid use disorder treatment as well.
Sure. So, developing skill sets in managing patients with addiction is sort of picked up a little over the past 10 to 20 years in residency programs, but it's still not optimal. And some of this has to do with number of individuals who choose to go into, say, addiction-based fellowships. Some of the residents in psychiatry find this population even more challenging than other populations. Variety of reasons, high sort of a no-show rate, and variety of things, that socioeconomic indicators, fewer support systems, that they're unable to make it to their treatment. So it's a long, hard slog getting people to go into any of these specialties. subspecialties. What I would recommend is, in the elderly especially, most of the physicians who see these patients are not geropsychiatrists or addiction psychiatrists. They're probably sort of primary care internists, or general internists as they're called, or family physicians. So workforce issues, while all attempts should be made and are being made to encourage subspecialties in addiction psychiatry or geropsychiatry, about 50%, and the data may have changed a little, about 50% of funded fellowships in geriatric psychiatry, so that's my subspecialty, are unfilled. About 50. Varies. Some will tell you 40. It used to be the lowest, 60. These are seen as very time-intensive subspecialties where the payoff is limited. And that happens to be the reality, but that to some degree dictates choice of specialty. So I would sort of say, even at the medical school level, some of the presentations we heard yesterday about trying to get physicians at a very early stage in training to recognize issues like addictions, such as and mental health issues, as extremely serious mental disorders and medical disorders, and not something for the other guy to sort of somehow manage. Destigmatizing language, trying not to be excessively harsh and premature in a judgment of patients with addiction and so on, has to start early. And the earliest it could start for the MDs is in medical school. Courses not just on the technical aspects of addiction, but on the psychosocial aspects of addiction that you talk so much about. I think that's where it should start. I would also recommend that, in my sense, the general internist, who's more likely to treat these patients? It's the primary care physician and it's the general internal medicine doc. Psychiatrists see the very sick ones, or the ones which have a lot of other comorbidity. And I think a required part of the residency should be some management. The third year of residencies have a lot of elective, and typically you find sort of it's invasive cardiology. It's one of those other specialties that draws a lot of folks, or part of an infectious diseases fellowship. These are the clinicians who will be called upon to diagnose, treat, and long-term manage these patients. And I think starting in the medical school, but residency programs is where there should be, I would urge some recommendation that this become a required part of, if it's, the old medical school thing is, if you don't inspect, I will not respect. If it's not asked on a test, then I won't study, because there's so many things I have to study, and I'm more interested in seeing what's on the test. That's not a healthy attitude, but that is sort of time efficiency when students and residents try to do what they're going to get rewarded for. That's a very long-winded answer, but it's a challenge. But I think all disciplines should sort of get into this.
Just real briefly, I think we're out of time. I welcome any participation in addiction awareness treatment from my obstetrician gynecologist colleagues, but I really approach this from more of a life course and sort of systems, and really it's easy, I'll put that in quotes, to take care of pregnant people during pregnancy just because of structural availabilities. What the critical period is really postpartum. And that's because of transitions, gaps, things that happen after delivery in terms of health insurance coverage, and also in terms of how we have siloed and structured reproductive health care. And obstetricians and gynecologists are actually not the best reproductive health care providers from a life course perspective, where there's one visit postpartum and then that's it. So really the key from an addiction treatment perspective is the first 3 trimesters is much more straightforward. It's that 4th trimester postpartum where things fall apart. And really finding ways when people, there's lots of gaps and transitions that happen between systems and across life courses and within chronic conditions. And the postpartum bridge is a essential one that is that I think we are just have massively failed in. And so I would think of workforce as not just sort of changing how OBGYNs practice in general and inclusive of addiction, but also considering utilization of systems that we have that aren't integrated into medical care either, like WIC, like home visiting, like early intervention. There's this whole universe of care that is not connected that well to sort of mainstream medicine. And really the solution is bringing all of those lines together, to speak to the needs of pregnant people.
I'm sorry to cut this off.
I have one thing that I think is very
Very
important.
short.
Very short. We're workforce development. So right now, the existing workforce has not been trained how to deal with this, is not going to go, they've already marched with their feet. They're not doing the data waiver training. Every resident in every specialty takes the STEP exams. Every residency program director teaches towards the STEP exams. If you got the STEP exam, if you got the USMLE to say, just to make an announcement, if you take the data waiver training course, you will pass this new section on the STEP exams. I guarantee you every program in the country will train towards that, and then you'll get a lot more eager treaters.
Thank you. Obviously, this was a very popular session, and one where we got quite a bit of very useful input. So let me thank everybody. Thank you, David, for moderating. So we will have one more session of the workshop after the break, and that will be followed by the opportunity for public comment. We have had a number of people sign in. If they are sitting in the audience, I warn you in advance, we will hold you to the 3-minute time limit. So please prepare that way. And once again, thank you to this panel.
Thank
we'll
you.
see you all in 11 minutes.